Hi, I'm Mr Shyamalan, consultant hand surgeon, and I'd like to do this patient educational video on Dupuytren's Contracture.
Hi Mr Shyamalan. Could you tell me what I could expect in a consultation with you?
Absolutely. Usually the GP has referred you because you either have a finger that is starting to contract down or have nodules which are thickening in the palm, and maybe there's a concern that you have a lump in the hand and he's not sure why you have a lump. Dupuytren's is incredibly common. He first described this thickening in the palm like a fibrous thickening where the tissue essentially becomes like a fibrous muscle tissue and starts to pull the finger down. And at worst stages, sometimes the fingers can come down quite significantly. It affects the ring finger commonly and the little finger, but you can get it in all the fingers and also the thumb. Generally with Dupuytren's, how I look at it is patients have generally normal function, so they can use the hand and they're not really in a lot of pain. But actually the main concern is it's starting to interfere with doing certain activities because it's getting in the way. So perhaps you're washing up, you're poking yourself in the eye, or you can't get your glove on properly, or patients aren't just sure why they got a finger contracture, really.
Thank you. And would I need any other investigations?
So, as we see you in a consult, I'll do a quick history, making sure you've not had any other injury to the finger. People can get contractile nature in their fingers following injury, and also Dupuytren sometimes can be triggered after an injury or straightforward injury to the finger. And also you have to look whether all the tendons are working, because if you've had an injury to the tendon, perhaps that's another reason why the finger's not straightening. But the key thing that can show with Dupuytren's is you can't, it's very difficult to straighten it out passively, which means I can't do that. It gets to a point. So a good test, if you just put your hand out flat for me, if a patient can keep their hand flat, generally they don't require any treatment for Dupuytren's. It's only when they have a bend and you can maybe put a pen underneath, and then it's time to say, okay, maybe it's time for some kind of intervention. And you look at the front of the palm and you're looking at the contractures and how they work their way up the finger. And sometimes it feels like a rolled cord, and a lot of people say to me, is that a tendon? I say, no, it's not a tendon, it's actually the abnormal tissue that's basically pulling down the finger. So probably wouldn't need too much more in the form of investigations. Really, it's a clinical diagnosis and you can mostly just understand that people have it. It's actually very common. It came over probably from a Northern European descent, very common in the Anglo-Saxon gene pool. It's one of the more common hand surgery conditions, and what I find is when people come to see me or GPs with other hand surgery conditions, actually you notice they've got these lumps and bumps and small contractures, and on the whole you don't need to do a great deal about them. So if it's not interfering with their function, I tend to say, okay, perhaps just get on and just make sure it's not getting any worse. But those ones that are starting to claw down quicker, then yeah, absolutely we should treat them, or certainly offer some treatment.
Thank you. And what else could it be? Can it quite often get confused with trigger finger?
That's a good question. I mean, trigger finger generally does present with a contracture as well. The difference is it can click out of position. And so patients normally, before the finger flexes to that position, will say, well, it clicked first. Or when you actually feel the tissue, you don't have that tissue. But okay, it can be quite difficult. But most of the time there's a good history for triggering or good history of trauma. And in Dupuytren's you can see it slowly progressing over time, so the patient will give you that history.
And what would be my treatment options then?
So in early stages, observation, as soon as it's starting to pull the finger down or any bend in this joint called the PIP joint, then we start to think about offering treatment. We used to have injections as treatment options, but this has now been withdrawn off the market. But we have been using a technique called percutaneous needle fasciotomy for many years, even before we had the injection treatments. And you know how I described that cord that pulls down the fingers, a little bit of local anesthesia under day surgery, and we just use a small needle to just open up the cord, and a gentle manipulation, and that generally really helps in early disease, but also Palmer disease. And it's certainly, I would say, my first line treatment option for kind of elderly patients who have physiological problems, who may not be fit enough for general anaesthesia, but I have successfully used it in other patients as well. If that fails to improve, generally physiotherapy, splints, etc. really have no evidence. So then the next option is open surgery. Open surgery is day surgery once again. We tend to do it under some kind of block, which essentially makes the arm go numb. And some people do simple, small, early disease under local anaesthesia. Local anaesthesia means just injections around the area you're operating, whereas block or general, there is full anaesthesia in the hand. And we tend to surgically remove the disease and then stitch the finger back together. I would say it's successful at improving the finger contracture. Not always. The more flexed the finger is, and the more it sits at about 90 degrees and the longer it's been in that position, they tend to get problems with the joint itself, and therefore the outcome is not as good, and perhaps it doesn't get the finger as fully straight, and recurrence rates, which means it comes back, are a bit higher as well. So definitely catching the disease at the right time and the right time to refer is when they basically can't keep their hand flat, and then that's the time to do it, as opposed to getting a finger that's very flexed down. Occasionally in revision surgery, when you're doing it, when someone's had surgery before, we tend to do a bit more aggressive surgery where we remove the skin and take a bit of a skin graft. And that once again has good results, but the rehabilitation's a little bit longer. Like any operation, there's general complications of the surgery from, wound problems, infections, things like that, which you can treat at an early stage if you pick them up. And that's what the follow-up's for. To problems related to the surgery itself, such as the small nerves and vessels that supply the finger. Certainly in primary surgery, damaging vessels and having problems with the blood supply is quite rare. But in revision surgery, it's a little bit more common. But occasionally the numbness in the tips of the finger, there's slightly a little bit of altered sensation if the nerves have been stretched. We mentioned stiffness, but occasionally stiffness and pain and some loss of function in the hand. It's rare, but that's where the hand therapy comes into it. So as a general rule, yeah, recurrence is probably one of the ones what people want to know. Is it coming back? And then also that return of function. Because if you can't make a full fist afterwards because the finger's been kept straight for a period of time, sometimes making that full fist, that gripping, is where people really struggle. And if their job is a manual worker and they want to grip. So that's why I try to encourage the movement straight away, really working hard on the grip. So successful procedure in improving the finger straightening, successful in respects that allows that palm and hand to open up. But once again, I'll discuss all this with the patient as to their pros, wants and wills. And at the end of the day, if they've had it for many years and it's not getting in the way, well, perhaps just leave it alone.
And so what would my recovery be like after surgery?
So we'd expect to do a wound check at about a week to 2. And as the wound starts to heal, you'll see the hand therapist who'll fit a plastic splint at night, normally for about 6 weeks, to keep the finger in a straighter position at night to prevent the contractures coming back. Plus a good therapy during the day. Start to use simple things like cutlery and light pens within a week. Once the sutures come out and you're a bit more comfortable in the hand and the swelling's starting to improve, you can start to drive, with a view to returning back to doing most activities by 6 weeks. The scar can be a little bit thickened and raised at 6 weeks, and so some sensitivity. But that improves with time. It's a lot of desensitization, scar massage. And so yeah, by 6 weeks to 3 months, I'd expect you to be doing all activities pretty much back to normal, really.
Great, thank you.
You're welcome.